So, with a continued session of the very different types of cirrhosis, the another one more important type of cirrhosis is pigment cirrhosis, which occurs in case of hemochromatosis. It's also called as bronze diabetes. So, this pigment cirrhosis, it it involves a clinical triad that is of micronodular cirrhosis and diabetes mellitus, that is 75 to 80% of them will present with diabetes mellitus, skin pigmentation, that is 75 to 85%. So patient will present with the pigment cirrhosis in case of hemochromatosis. They are also called as bronze diabetes because of diabetes and the skin pigmentation. So because of these two clinical features, this is also called as bronze diabetes. So usually in this patients, the usually normal iron pole will be 2 to 6 grams, which will be exceeded to 50 to 60 grams. So few points regarding hemocirrhosis. It is nothing but excessive iron accumulation in tissues without the tissue damage. Hemochromatosis, it is excessive iron accumulation which is associated with the tissue damage, which occurs in case of pigment cirrhosis, where there is an excessive iron accumulation within the hepatocytes rather than the Kupffer cells, which leads to the cirrhosis. So basically this pigment cirrhosis caused because of hemochromatosis. So we should know much about hemochromatosis. It is classified into primary and secondary. So the primary is idiopathic or genetic. Secondary causes can be of has been listed here. One is anemias, especially thalassemias and sideroblastic anemias. Especially thalassemia patients should receive blood transfusion every 6 months. So it's because of the multiple blood transfusions there will be a excessive iron overload. And patients with alcoholic cirrhosis, portocaval anastomosis, prolonged ingestion of iron, and this secondary type of hemochromatosis is also common among these Bantu tribes in South Africa as due to the prolonged ingestion of iron laden wine, which is called as Kafir beer. So primary or idiopathic type of hemochromatosis occurs due to the overexpression of this HFE gene, which is located on this chromosome 6p at HLA gene locus. As it overexpresses or it is mutated, it causes an increased absorption of dietary iron, which is an autosomal recessive inheritance, which leads to the excessive accumulation of iron in the periportal hepatocytes. So primary type, it's most commonly more females to female ratio. It goes in of 5 to 7:1. So pathogenesis, when clinically we can see the patient will presenting with the features occurs when there is more than 20 grams of iron when it gets accumulated. And as we know, iron is very toxic to the tissues because by causing there is a lipid peroxidation with the release of free radicals which are highly hepatotoxic, and excessive accumulation of iron granules will also cause the stimulation of collagen formation, and they cause direct action on DNA, which is a lethal injury. So patients in hemochromatosis not only will affect liver, it also affects other organs, which are very importantly pancreas, myocardium, joint linings, lymph nodes also will be affected, and skin. So this is a gross picture of the liver showing hemochromatosis. You can see liver will be uniformly enlarged along, and it takes up the color of chocolate brown in color due to the accumulation of the iron granules. And this is a pancreas and lymph node. So this is a microscopic image of hemocytin in hepatic and Kupffer cells. Especially we can see the presence of this hemocytin granules, which are most commonly accumulated within the hepatocytes and less often in the Kupffer cells. Especially these iron granules will accumulate in the portal hepatocytes, causing the portal fibrosis most commonly. So as iron can be demonstrated by this is a special stain which can be used, that is Prussian blue stain or a Prussian blue reaction, which is demonstrated by Paul stain. The iron granules has been taken out by the special stain. So this is on as the same special stain, that is Paul stain, on a cirrhotic liver due to hemochromatosis, which can be noticed that thickened fibrous septa, which has divided the hepatic parenchyma into the very uniformly sized nodules, micronodules, wherein the hepatocytes having this hemocytin granules has been shown up by the special stain, and even there is a sparsely inflammatory infiltrates. Clinically, it most commonly as it affects males more than 40 years, hepatomegaly, abdominal pain, as it it's not only affect liver, it also affects skin, endocrines, so patient will person with diabetes mellitus, skin pigmentation, that is gray color, cardiac arrhythmias, atypical arthritis, and hypogonadism. So coming to the biochemical investigations, in case of uh, iron level, serum iron level will go more than 250 micrograms per deciliter. This is the normal is this, and serum ferritin goes more than 500 nanograms per milliliter. Transparent saturation will be 100%. Yeah, this type of cirrhosis, it can be diagnosed in a pre-cirrhotic stage and can be prevented. And iron, as due to the excessive accumulation of iron granules, the liver size will be dramatically increased, and it will be accounting for more than 22,000 micrograms. And as in case of primary or idiopathic type of hemochromatosis, investigations of the family members is also important. So the next type of cirrhosis is due to the Wilson disease. Wilson disease is also called as hepatolenticular degeneration, as there is a abnormality in the copper metabolism which will cause excessive accumulation of copper, toxic levels of copper in liver, and also due to the excessive accumulation of copper in brain, it will cause the degeneration of basal ganglia and eye. So usually this is a autosomal recessive inheritance. So the normal copper metabolism, so whatever the normal dietary copper will be absorbed in stomach and duodenum and will be transported to liver by combining with albumin. So here, when it combines with albumin, when it will be released to the within the hepatocyte, it will bind with the alpha 2 globulin to form this ceruloplasmin, so which can be transported. The copper will be transported through in the form of ceruloplasmin into the sinusoids from the hepatocytes, wherein so this is the normal pathway. How does it occur? So usually in Wilson disease, there is a mutation in the gene, that is ATP7B. It's located in the 13th chromosome. Usually there is, due to the mutation of this gene, there is a failure for the inactivation of this copper transporting ATPase, where there is a failure for the binding of copper to the alpha 2 globulin, and there is a failure for the formation of ceruloplasmin. So this is how ceruloplasmin fails to get formed, and it leads to the excessive accumulation of the toxic copper within the hepatocytes, and the copper will not be transported in the form of ceruloplasmin into the sinusoids. So that leads to the Wilson disease. So what happens in liver findings in case of Wilson disease? Following the fatty change and acute hepatitis, chronic hepatitis, and the cirrhosis. So in the Wilson disease, the biochemical abnormalities includes there is a decreased serum ceruloplasmin, increased hepatic copper, which is more than 250 microgram, and there is increased urinary excretion of copper. However, serum copper level estimation doesn't carry any of the diagnostic tool for the diagnosis of Wilson disease, and these are called as Kaiser-Fleischer rings. When there is a excessive accumulation of this toxic copper in the descending membrane of the limbus, these greenish brown deposits which will be seen in the descending membrane. So clinically, usually patient will present with acute or chronic liver disease, and age at onset and clinical presentation might vary. And as Wilson disease patient, there is a bilateral degeneration of the basal ganglia of the brain. So patient might present with neuropsychiatric manifestations, Parkinson's disease like syndrome. So another type of cirrhosis is biliary cirrhosis. So biliary cirrhosis, as it's also one of the type of cirrhosis which has been classified into primary and secondary. So primary biliary cirrhosis, it occurs due to the destruction of intrahepatic bile ducts and chronic progressive cholestatic disease. All this will lead to portal inflammation and scarring, or fibrosis leads to cirrhosis and liver failure. So first and foremost, primary biliary cirrhosis is most commonly will be seen among females, with male to female ratio accounting for 1:9, and due to the, especially it is of autoimmunotype, so there is a destruction of intrahepatic bile ducts which causes excessive stasis of bile, will leads to this further pathogenesis. So as it is explained, most commonly it affects 40 to 50 years of 50 years. So most of them are autoimmune due to the most commonly, that is anti-mitochondrial antibodies, which are of 95%, and due to the reactivation of autoreactive T lymphocytes around the bile ducts, which cause the florid bile duct proliferation, along with the activation of inflammatory response causing the portal fibrosis and scarring, leading to cirrhosis. And there is no switch from IgM to IgG. So familial incidence also is most commonly noted in case of primary biliary cirrhosis of HLA origin. Most of the time, this primary biliary cirrhosis is also associated with other autoimmune disorders, that is Sjogren's syndrome, thyroiditis, scleroderma, rheumatoid arthritis, membranous glomerulonephritis. So morphological stages, it includes the 4 stages in case of biliary cirrhosis. One is floral bile duct proliferation, that is autoimmune destruction of bile duct epithelium, further lead to the proliferation of this bile ductule with the activation of the inflammatory autoreactive T cells, with the accumulation of the inflammatory mediators like cytokines, and there is accumulation of this monocytes and lymphocytes. It further leads to portal and bridging type of fibrosis, which leads to cirrhosis. So bridging type of fibrosis is nothing but there is a fibrosis which occurs between the central vein to the portal triad. So this is a bridging type of fibrosis. So these are the 4 stages which occur in case of which are involved in a pathogenesis of primary biliary cirrhosis. So this is a gross picture of primary biliary cirrhosis. As we can see, the section of the liver shows diffuse micronodules, and the liver characteristically it shows greenish color due to the bile. So you can see the uniformly varying sizes of this micronodules, slight green in color. And this is a microscopic picture with the bile duct surrounded by the immense inflammatory, chronic inflammatory cells, that is all the lymphocytes and even. So this is a picture where the portal tract, which is associated with the accumulated with the excessive inflammatory response, that is lymphocytic infiltration, and anywhere we can even see the granulomas in case of primary biliary cirrhosis. Clinical features, as bile entering into the blood, that is insidious in onset, it might cause pruritus, jaundice in the later stages, xanthoma and xanthelasma, and as there is a accumulation formation of these micronodules, yes, liver will be enlarged. Patient will be presented with hepatomegaly. Biochemical investigations, hypercholesteremia, alkaline phosphatase, as it is a liver enzyme which will be increased due to the, as there is a liver function has been affected, bilirubin will be increased. As in case of primary biliary cirrhosis, this it is of autoimmune type, this immunoglobulin of IgM will be increased. In case of Wilson disease, yes, this copper accumulation, that is toxic copper levels, serum copper levels will be increased. Prognosis, in about 2 decades, it can lead to hepatic decompensation and death. So what is secondary biliary cirrhosis? It is cirrhosis which occurs due to the prolonged extrahepatic biliary obstruction, which can occur because of the gallstones or due to the carcinoma of head of the pancreas, and ascending cholangitis, which can occur because of the superimposed any infection causing fissure with the inflammation of the biliary tree, cholestasis, which occurs because of the gallstone, which is like already told. All this also the same stages, that is florid ductal proliferation, with the proliferation of the bile ductule, with the activation of the inflammatory mediators like cytokines, with the accumulation of lymphochronic inflammatory infiltrates in the form of lymphocytes and giant cells. Further, there is a stage of fibrous scarring, that is portal fibrosis, which leads to micronodular cirrhosis. So the same pathogenesis, the 4 stages, has to be remembered. So this is a picture. You can see the presence within the hepatocytes. They have been studded with the bile thrombus. So many of the hepatocytes contains this bile plugs. So in this case of cirrhosis, and there is a chronic inflammatory infiltrates in the form of lymphocytes. You see.